Yeah.
Just a minute, Dr. Muhammad.
Okay.
Just I start the YouTube live.
Can you see the presentation now?
Yes. Just yeah, we can see.
Okay. Shall we start now?
Just a minute to be sure the YouTube is yes.
Can you see?
Yes, you can start.
Okay. Good evening, everyone. I hope everybody is safe during this unprecedented COVID pandemic. And I would like to thank Dr. Mohammed for giving me this opportunity. And it's a great pleasure for being a speaker along with the international renowned speakers like Dr. Tarek Sharaway and Dr. Nawaz. So it's been 4 years since I finished my fellowship, and I've been working as a consultant at LV Prasad Eye Hospital. And I've learned trabeculotomy from my teachers, Dr. Sitisha Sendil and Dr. Anil Mandal. And today we are here to discuss a few tips and strategies on how to do a trabeculotomy successfully. So at the outset, primary congenital glaucoma is a rare eye disorder with 0.01 to 0.04% of total blindness. In the Western countries, the incidence is 1 in 10,000 births, whereas in India, in the combined states of Andhra Pradesh and Telangana, it is 1 in 3,300 births. The incidence is more because of the increased incidence of consanguineous marriages here. The involvement is usually bilateral with a slight preponderance in males. So congenital glaucoma accounts for 4.2% of all the childhood blindness here. And primary congenital glaucoma presents with the classical triad of increased tearing, photophobia, and blepharospasm. Whenever a child presents like this with some signs of ophthalmos, megalocornea, presence of Harp's striae, iris anomalies, corneal edema, and disc cupping, the diagnosis of primary congenital glaucoma is made. In extreme cases which are not treated and who present to us at a later age, around 5 years, 6 years, because of the chronic glaucoma, there is severe glaucoma because of the thinning of the sclera, there is staphyloma, corneal scarring with vascularization, and the prognosis becomes extremely difficult. So it's very important to treat these patients early at the time when they're present. The imaging technology that we do is, first thing is the B scan to rule out any intraocular tumors, because these tumors can mimic PCG, and also to know the axial length and the other parameters. Ultrasound biomicroscopy has also been described in these cases, which presents with variable corneal thickness depending upon the edema, and then the larger anterior and posterior chamber depth, thinner iris, larger anterior chamber angle, loss of the iris crypts, thinner lens, larger zonular length, and thinner ciliary body. It also helps us to rule out other anomalies which can cause developmental glaucoma, like iris anomalies. So this is a patient which I operated, presented typically like a PCG patient, but when we did a UVM, we saw that the iris is totally plastered to the cornea. So there was no pupil and there was total pupillary block. So when we separated the iris from the cornea and created an pupil with vitrector, this is how we can see the iris. So UVM helps in also identifying the anomalies, like iris anomalies like iris cysts. You can also make out the cataractus lens. So apart from this, the pure PCG, whenever a patient presents with classical signs and symptoms, after doing a B scan, we pose them for examination under anesthesia. Lacrimal patency has to be ascertained. If the cornea is hazy, then we will be able to only measure the corneal diameter, intraocular pressure, and the corneal thickness. If the cornea is clear, we can do refraction and presence or absence of Habstri, the anterior chamber depth, whether there is any presence or absence of iris anomalies, lens status, indirect ophthalmoscopy to know the disc status, and then the gonioscopy to know the anomalies in the angle, and CCT, axial length, and keratometry. So once we have diagnosed that it is a case of primary congenital glaucoma, this glaucoma is a surgical disease. So the various surgeries have been described. Historically, in 1900s, it was told that this disease does not have any treatment. But it was Otto Barken who first told about goniotomy in 1938. And for several years, we were doing goniotomy, and it was in 1960 when simultaneously Burian and Redmond Smith discovered or developed this trabeculotomy ab externo, and Burian did an Marfan syndrome baby. So, and then these were later modified by Harms, Danheim, and McPherson. Nowadays, there are many surgeons who do this illuminated microcatheter 360-degree trabeculotomy. So what is that which is difficult in children is because of the enlarged eyeball, because of the high intraocular pressures, the tissues are very delicate. There's distorted anatomy because of the ophthalmos. It's a large eye. The sclera is thin and the rigidity is reduced. And they have thick and active TNS capsule, which causes increased risk of scarring. And they're more predisposed for the surgical complications like hypotonic, and they need repeated examination. So there have been goniotomy, which is being described with good surgical success, but in India, not like Western population, majority of the children present with corneal edema, with elevated intraocular pressure, and this in these situations, goniotomy cannot be done. And we know that trabeculectomy alone, the success rate is not very high. So we in India combine trabeculotomy with trabeculectomy, and we have reported a good success rates of around 90, about 90+% in first year and 70% in third year. So what are the advantages of combining these two? One thing is it can be done in hazy corneas. There is no lens that is required, and it deals with the primary problem of increased meshwork resistance. Also, that creates an additional pathway which causes the outflow of the aqueous. And the disadvantages are that the identification of SCHLEMM'S canal is difficult in eyes with distorted anatomy and in ophthalmos eyes. Complications such as hyphema, cyclodialysis, irododialysis, if not properly performed. And there is no need for using sharp instruments in the eye inside the AC, which increases the risk of cataract formation or iris changes. So the surgical success rates have been increased by combining these two. So the main problem in trabeculotomy is identifying the SCHLEMM'S canal. What is SCHLEMM'S canal? It is formed by bridging the scleral sulcus by the trabecular meshwork, which converts into the tube. So this SCHLEMM'S canal basically drains into the episcleral veins and the conjunctival veins through the two pathways. One is directly through the aqueous veins, and the other one is through the intrascleral or the deep scleral plexus, and then into the anterior ciliary vein, superior ophthalmic vein, facial vein, and then finally into the cavernous sinus. So identification is very important in surgeries or such as ab externo trabeculotomy, in 360-degree illuminated microcatheter assisted trabeculotomy, and also in Prolene suture or a nylon suture 360-degree trabeculotomy. And non-localization of the SCHLEMM'S canal, the reported incidence in our series is from 3 to 6%, is mainly in the beginner's hands because of the variable thickness of the superficial flap. The superficial flap has to be of adequate thickness to know the anatomy and to identify the SCHLEMM'S canal. And second thing is, in large eyes where the anatomy is distorted, there is displacement of the SCHLEMM'S canal posteriorly. So this is a video which self-explains. There's a voiceover about how to perform a successful trabeculotomy. This, we have recently won a ASCRS Film Festival Award for this. I will play this now. Trabeculotomy alone or combined trabeculotomy with trabeculectomy is the preferred surgical intervention for the management of congenital glaucoma. Ab externo approach is used to identify and cannulate the Schlemm's canal. Identifying the Schlemm's canal is the most critical step to perform trabeculotomy and demands training and microsurgical skill. Identification is challenging since many of the ophthalmic eyes have altered limbal anatomy, making it difficult to locate the Schlemm's canal. Exploring the Schlemm's canal is the key step for several surgical procedures like trabeculotomy, viscocanalostomy, and deep sclerectomy. So we are removing the Schlemm's canal here on either side of the radial incision. This step is not actually required during trabeculotomy. This is just to show how the Schlemm's canal appears ab externo. In this video, we describe certain tips to easily identify and locate the Schlemm's canal so as to successfully perform trabeculotomy. After creating the superficial scleral flap of appropriate thickness, surgical limbal anatomy is carefully identified. Adequate care should be taken while dissecting the scleral flap, especially near the limbus. Surgical limbus is a 1 to 1.5 mm wide zone and is divided into anterior narrow grayish blue band representing the trabecular meshwork which is overlying the corneal lamellae and posterior wide opaque sclera. The junction of these two bands is the external landmark for Schlemm's canal, which is commonly situated 2 to 2.5 millimeters behind the anatomical limbus. And it can be explained by saying, where white meets blue, Schlemm's waits for you. The second tip is the presence of one or more perforator vessels entering the area of Schlemm's canal. One of the tips is a depression at the area of Schlemm's canal. The continuity of two zones is not smooth and there is a dip between blue and white zone which marks the junction. Once identified, radial incision of 1 to 2 millimeters length is first made across the Schlemm's canal region under high magnification, which is gradually deepened with a sharp blade until it reaches the external wall of the Schlemm's canal, indicated by ooze of aqueous, rarely mixed with blood. The lower arm of the trabeculotome is introduced into the canal, and once 90% of the trabeculotome is within the canal, it is rotated into the anterior chamber. Minimal resistance is felt, and one arm of the trabeculotome rotates freely into the anterior chamber over the iris. The rotation should be parallel to the iris. If it is too anterior, it can cause Descemet's detachment. And if it is too posterior, it can cause damage to the iris and crystalline lens. Thus, to conclude, the excavation or dip between the two zones, along with the location of the perforator vessel, most often confirms the presence of the Schlemm's canal. Appropriate identification of the Schlemm's canal and precise movement of the trabeculotome would help us to successfully perform trabeculotomy. After successful trabeculotomy, compare and contrast the appearance of the left cornea in a child with left congenital glaucoma with acute eye drops at presentation at 2 weeks, 2 months, and 6 months after surgical technique. This is one of the surgery where the ooze of the aqueous through the collector veins, perforator vessel veins is very clearly noted. So this is where there is the location of the Schlemm's canal is there. And one more tip I learned recently from Dr. Ken Mitchell's talk is that whenever they're trying to do this trabeculotomy and this step comes, they ask the anesthetist to decrease the blood pressure and also to give minimal pressure over the jugular veins. this actually increases the flow through the Schlemm's canal, and thus the blood or the aqueous ooze increases. So this is one more tip that I've learned recently. So the various surgical complications intraoperatively in our studies is that non-localization, premature entry, Descemet's detachment, which is prolapse, and severe hyphema. Because of the if the movement of the trabeculotome is little posterior, it damages the iris root, then the bleeding happens. So this is one of my patients where the blood happens, and if it is just one time bleed, the clot can be easily removed with the help of the Simcoe cannula. But sometimes what happens is the iris is very anomalous, and there is lot of blood which accumulates, and it is basically the bleed from the walls of the trabeculectomy ostium. Then it is very difficult to control this ooze. So we can see that there is extensive bleeding that's happening, and this, even though we tried cauterizing these bleeders, we could not cauterize, and the whole anterior chamber got filled with the blood. So even after the completion of trabeculectomy, there is so much of bleeding, and then we have to clean this, wash this blood with the help of the Simcoe cannula, and then in such cases, we have to leave the anterior chamber with air bubble, because the bleeding doesn't stop otherwise. In the initial times when we were doing, so if you don't do it slowly, there can be an inadvertent perforation. Once we gradually deepen the initial radial incision, if you're not careful enough, if you observe in this video, so still now I'm not seeing any ooze. So if you little more, then there is a perforation. So now it is through and through, and we cannot do any trabeculotomy now. So it's very important that we are very careful. In few eyes where the disease is very advanced, the Schlemm's canal is displaced very posteriorly. So in such eyes, when we do trabeculotomy, and if we try, it is very difficult. So this is where the chances of vitreous prolapse is very high. So this was eye which was advanced disease, and the baby had no vision in the other eye also. This was the better eye. So now you can see that the vitreous is coming, which can be managed with a vitrector. But in such eyes, it is always better to do trabeculectomy alone, and rather than trying to do a trabeculotomy. And sometimes when we do a PI, if it's a sectoral iridectomy, this is how it looks. This is superior iridectomy. So the patient, sometimes the parents are very cautious, and cosmetically they ask, what is this? It has become so big. So these are very few eyes that we have faced complications and have put. And apart from that, if we follow the steps correctly, and if we do the trabeculotomy, the survival function is very good. It's almost 94% at 1 year to 86% at 3 years. So my take-home message is primary combined trabeculotomy and trabeculectomy is successful in our eyes, both in congenital and developmental glaucoma. It's very important to do a meticulous surgery with microsurgical skills for easy identification of Schlemm's canal. In very enlarged eyes, like more than 15 mm and stretched limbus, where the anatomy is likely to be distorted, it is better to do a trabeculectomy alone. And we do face complications such as hyphema and vitreous loss, which needs to be managed intraoperatively. Thank you.
Thank you very much, Dr. Rashmi, for this nice presentation. Dr. Tariq, do you have any comments on trabeculectomy and success rate, and what is your recommendations to do?
Let me first thank Dr. Rashmi for an excellent presentation. Really, really beautiful. I mean, she has some of the best mentors in the world when it comes to trabeculotomy. People that I have worked with, Dr. Mandal is a giant in our field, of course, and you're probably a star student. The video quality is incredible, and it cannot have been better illustrated. So really good. My own technique is a bit of a twist on what you are doing. I am actually doing a trabeculotomy, deep sclerectomy in congenital cases. So I do a trabeculotomy just like you've shown, but I also do a deep sclerectomy. In essence, I want to make sure that I don't have only filtration through the conventional pathway, but doing a deep sclerectomy on top of that, just like you're doing a trabeculectomy, with a trabeculotomy ensures some sort of a subconjunctival filtration, which to my mind is something that helps in certain number of cases. But the advances or the advantage of using a deep sclerectomy instead of a trabeculectomy is that you have an intrascleral bleb. So the bleb is not too high as in trabeculectomy. And that for me is a good option, because in that way I can even offer to some of the patients to put contact lenses if in some cases. And in my hands, comparing historical data with what we're doing now, combining trabeculectomy with trabeculotomy was associated with a certain higher significant incidence of cataract in children compared to deep sclerectomy, trabeculotomy. But I mean, there are no big data, and I know that the Indian school in congenital glaucoma has been teaching us for decades. So thank you very much for a brilliant presentation.
Thank you. Dr. Tarak, do you do this 360-degree illuminated microcatheter or the Crowley suture?
No, I've tried that, but I've seen studies that show that 180 does not make a big difference from 360. So a couple of studies have been, and information has been shared with me from colleagues in Norway and in Cairo. And so I have not really moved into 360 degree. I'm still doing trabeculotomy as wide as possible with deep sclerectomy.
Dr. Rashmi, is there any age limitation to do trabeculotomy for children? I mean,
I mean, we do up to 3 to 5 years. We are not, even though we do trabeculotomy in older children, the success is not it is almost similar to what we do in trabeculectomy alone. So only in young children, Mandal has done even as young as 2 days, he says, but I prefer to do at 3 weeks of the age of the baby. The largest, the oldest the Dr. Mandal has done is around is 5 years. So older the children, I don't think the benefit is more. Trabeculectomy alone is.
When I just practicing trabeculectomy, I face that hemorrhage will be the incidence of hemorrhage in older children will be more, especially more than 2 years. So, and almost all my cases more than 2 years when I start trabeculectomy, bleeding is happening. Less than 2 years, it's peaceful surgery actually.
And one more thing I've seen is the older the children, the chances of choroidal detachment and suprachoroidal hemorrhage is very high compared to the young children, because the pressure is very high for long duration, and then suddenly when we decrease the pressure, the risk of hypotonic related complications are very high.
Yeah. Thank you very much, Dr. Rashmi. We'll start with the second topic. It's okay, everything can see, everyone can see. So actually, it's our great honor to be here with Prof. Tariq Sha'rawi. Thank you very much for joining us, Prof. Tariq. Thank you, Dr. Rashmi and Dr. Nawaf. I'm going to speak about trabeculectomy step by step. As we know, the first publication of trabeculectomy was by Dr. Sirens in 1968, and up to now is still the gold standard of glaucoma filtering surgery. The success rate may reach 200% in experienced hand. It is very simple procedure, but need a lot of care to avoid complications and get more success. In 2005, Moorfields Safer Surgery System is designed to improve the surgical outcome, and many surgeons just use it as a template to perform their surgery with their own modifications and variation. Moorfields Safer Surgery System is based on a few different steps comparing to what was earlier. Corneal traction suture, fornix-based conjunctival flap, large scleral flap, large area of anti-metabolite treatment, a small controlled sclerostomy, watertight conjunctival closure. So if we just came to surgical exposure, either with corneal traction suture or superior rectus parietal sutures, and most of the surgeons, they prefer corneal traction suture to avoid the complications of parietal sutures, which may be either rectus hematoma, conjunctival buttonholing, disinsertion of the muscle, post-operative ptosis, and globe perforation. Corneal traction suture can be done 1 millimeter anterior to the limbus with with 7-0 ficryl silk or nylon suture, and then rotate the globe downward. Only just we should not put it deep to perforate the cornea, and it should not be also superficial to cause Swiss cheese wiring. Superior rectus parietal suture also is excellent to exposure the field of the surgery, and actually I'm comfortable to use the superior rectus parietal suture, and I find it nice. I didn't face any complications up to now for superior rectus parietal suture. Coming to conjunctival flap, it can be either fornix-based and limbal-based, and most of the surgeons, they prefer to do a fornix-based because it is easier and a little bit faster than limbal-based. And also in limbal-based, the blip will be a little bit localized and elevated comparing to the fornix-based, where the blip will be more diffused and more posterior. If we just came to compare the fornix space with the limbal base, the only disadvantage of fornix space is to with red line, in which the increase the incidence of wound leak and need multiple small sponges of anti-metabolites comparing to the limbal base. That's why most of the surgeons prefer to do fornix space, but I think it's a matter of practice. If we just practicing either fornix or limbal base, everything will be okay. I am used to do all my pediatric cases limbal based conjunctival flap, and for adult I use fornix based conjunctival flap. The only thing that in incision or in creating the conjunctival flap, we should respect the conjunctiva. Trabeculectomy is the surgery with which the conjunctiva take maximum respect. The conjunctiva should be handled very gently to avoid buttonholing. Posterior dissection and make a wide bucket should also be done. So if we can see this video, just taking a conjunctival incision from the limbus, I like to take it a little bit anteriorly. I don't like to do the incision from the side, just to keep the contour of the conjunctiva. And then just dissect the conjunctiva posteriorly. We take just incision should be 5 to 10 millimeters from the limbus, and then we dissect 6 to 8 millimeter posteriorly. This dissection and making a bucket is useful just to for the bleb itself, and also to just putting the sponge of mitomycin inside. So then we came to hemostasis. Hemostasis with it should be minimal and adequate because the blood will act like a trigger for healing process and will induce fibrosis. Cautery should be light. It should not be more than that. It should be very light to avoid contraction of the sclera, and we should also avoid cauterization the margin of the conjunctiva, which it might cause also leak after that. So cauterization should be light enough. And then application of antifibrotic agents. The most common wound modulating agents used is mitomycin C with a dosage of 0.2 to 0.4 milligram per ml and the time of 1 to 3 minutes maximum using Wexel sponge. And we should avoid contact the wedge of the conjunctiva and treat as large area as possible. Here we are just putting a sponge, avoiding contacting the margin of the conjunctiva. Posteriorly, we are putting it. But in Moorfields eye surgery system, they are recommended to treat large areas. So we can just put more than one piece of sponge of mitomycin. We can put 3 pieces, one in the center and 2 on the side to treat a large area as possible. Another alternative to mitomycin is a collagen implant or Oligen, which will reduce the complications of mitomycin. We use this 6 millimeter at the end of the surgery after suturing the scleral flap. Then just we put it inside a little bit more posterior and then close the conjunctiva meticulously. The only side effects, it's just difficult to do suture laser suture lysis post-op with Oligen implant. And comparing to the mechanism of action, Oligen implant will just do a physiological wound healing, comparing to the mitomycin, which causes thin epithelium, in which there is a lot of complications may happen, like cystic polyp, endophthalmitis, polypitis, and so on. So a lot of studies just comparing the mitomycin to Oligen, and all of them, they conclude that the use of Oligen implant is comparable to use of mitomycin C. However, some studies mention that still it is suboptimal comparing to mitomycin. After applications of mitomycin C, it's better to irrigate the sclera and subconjunctival space. And during this irrigation with 20 cc to 30 cc PSS, I like to do hydration of the conjunctiva. This hydration of the conjunctiva will just act as a prophylaxis against buttonholing during manipulation of the conjunctiva. A scleral flap can be done with half to 2/3 of a scleral thickness, and the exact size and shape of the scleral flap doesn't seem critical. It might be triangular, rectangular, quadrangular, or rhomboid in shape. I was just doing a rectangular, then I compared to triangular flap, and just take 4 by 4 millimeter scleral flap. During dissection also, we should just deal gently with the scleral flap to avoid also any button holing. And dissection of the sclera can be done either using the blade itself or also using a crescent. And when we dissect, we should just reach the limbal area and get through the clear cornea also. And it's better just to avoid dissection the side of the scleral flap to promote posterior direction of aqueous flow. So if we just reach this gray area, the blue, yeah. So and then go through a little bit through the clear cornea, so it's enough. So then we should do paracentesis to enable the surgeon to maintain the EC and to test the vicinity of filtration surgery by injecting the fluid into the EC. Sclerostomy should be 1.5 to 2 by 2 millimeter, and a very small hole can drain more aqueous than required to control IOP, but it should be overlap all the sides of the scleral flap. We can use also either a blade or the bunch. I like to use Kelly's bunch, and just I cut a little bit anterior to the scleral spare till I reach the scleral spare. So if just we see a blood oozing from there, that means we are reaching the scleral spare, and we should not go beyond that. As we see that the sclerostomy is small and also covered by all sides by the scleral flap to prevent exposure of the margin of the sclerostomy. Peripheral iridotomy should be also performed to reduce the risk of iris incarceration and occlude the sclerostomy. So it should be wider enough than the sclerostomy to prevent any iris incarceration or occlusion of the sclerostomy. Coming to most important step in trabeculectomy, which is scleral flap closure. We should not repair or suturing the scleral flap like just ruptured globe repair. So its leak should be there, and allow the aqueous to go or to flow should be also. Although some surgeons they prefer to close the flap tightly to minimize the post-operative anterior chamber shallowing, but most of them they need to do laser suture lysis post-op, or they need to modify their suturing to do conjunctival releasable suture. So it must keep in mind that the technique of scleral flap suturing regulates the flow of aqueous. In triangular scleral flap, one apical suture is enough for trabeculectomy. And then if we see that there are, this eye is soft and there are a lot of leak of aqueous, we can just add another two sides sutures. But the apical sutures should be the most tight one, and the two side sutures should be a little bit loose. We should pair the sutures also, and then the side sutures can be done. Big bite during suturing should be taken to facilitate laser suture lysis or just do a releasable suture for that. Pairing of the sutures and then cut. So after just finishing the suturing of the scleral flap, it is just important to test the integrity of the scleral flap before closing the conjunctiva. So I like just to use a trypan blue to see the integrity of the scleral flap and how much the amount of aqueous is flow from the scleral flap. And if it is like this, so yeah, this is a good sign of working blip. And there is another one also. Just put one drop with a single apical suture. Yes. So conjunctival closure should be meticulously closure, and there are a lot of techniques to close the conjunctiva. I prefer to use 10-0 nylon suture, doing two conjunctival closure, taking a big bite, pulling the conjunctiva, and then tightly close suture, close the conjunctiva. Other surgeons, they prefer to use 8-0 Ficryl and close the conjunctiva also tightly. And other surgeons, they prefer to use matrix sutures or continuous sutures. And also some, they prefer to do third suture here in the middle of the conjunctiva flap. But if we just see after suturing 2 side sutures from the conjunctiva is more than enough for me, and we can see that it's tightly closed and no leak also is there. So after finishing this, we should also test the formation of the bleb. We can see how the bleb is formed nicely without any leak. Also here we can see how the nicely bleb formed, and then coming to post-operative management, topical steroid, just prednisolone acetate for over 6 weeks will suppress the wound healing. Topical antibiotics for 4 weeks post-operative, and I like to give topical Midriatic or cycloplegic to prevent anterior chamber shallowing and the risk of malignant glaucoma. Follow-up control, see the patient 1 day post-op, and then within 3 days, then weekly for 1 month. If IOP controlled, continue to see the patients every 3 to 4 months. This is a case of within 2 weeks post-op, we can see that bleb is nicely elevated, diffused, vascularization is okay, and we can see also that conjunctival sutures, which can be safely removed at this time. Thank you very much. Hello?
I have a question, Dr. Mohammed.
Yeah.
Have you ever used the subtenons mitomycin injections, or you always use the sponges?
I always use the sponges, but I prefer it's okay to use the sponges. Some they are trying to do subtenon injection, but I don't like to use it. Okay. You are doing like that.
Sometimes, yeah. Sometimes I use injections. Sometimes I use the sponges, regular sponges. But mainly, most of the cases I use the injection, subtenon injection.
What about your experience with Ologen?
No, I don't have experience actually with Ologen.
Yeah.
But I wish I tried to start Ologen, but I don't have that experience with it.
Yeah. Dr. Rashmi, I think she has experience to do TRAB with Ologen. What is your experience to do TRAB with Ologen comparing to the mitomycin?
Yeah. We actually do Ologen TRAB, especially in eyes where the sclera is very thin, expected to be like in connective tissue disorder, or in JOAG, or in high myopes, where the MMC might have some deleterious effects on the eyes. Where we use Ologen, and the results are great. It actually decreases the scarring based on the number of fibroblasts that are formed also is less, and the scarring is less. We have done a prospective study with comparing Ologen with MMC, and the results are not different. So it is an alternative to MMC. We cannot say that it is better than MMC, but in eyes where we feel that MMC might cause some problems, is where we are using Ologen.
Okay, thank you very much. So I just we'll move to Dr. Nawaf Al-Marzouki. He will speak about glaucoma drainage device. You can start, Dr. Nawaf. The questions at the end we can answer any questions. Is there?
Just try to share my. You can see the presentation?
Yes, we can see.
Okay, first of all, hi everyone. My name is Nawaf Al-Marzouki, a glaucoma consultant at King Abdulaziz University Hospital. I would just give a brief talk about glaucoma drainage device, indications, and example how to implant glaucoma tube. As we know that glaucoma drainage device share a common design consisting of a tube which connects to an end plate. The tube usually inserted in the eye and the shunt to aqueous humor from the anterior chamber to the end plate, which located in the equatorial region of the globe. So as the aqueous pool in the end of the plate and surrounding capsule, the aqueous then passes through the capsule and it's absorbed by periocular capillaries and lymphatics. The tube shunts are different design. It's been used for decades and it's have different design with respect to the size of the tube, the material composition of the end plate, which is the most commonly silicone or polypropylene, and many studies that show that silicone has less inflammatory response than polypropylene. According to the mechanism of the valve, there is a two type of glaucoma tube implants, the non-valve tubes and the valve tube. The non-valve tube, which commonly named Barvolt and Molteno, which is not commonly used nowadays. And also there is another version of Barvolt that's called Orolap, which usually used in India. The mechanism, there is no mechanism that impede the aqueous flow in these type of non-valved tubes. So usually must ligate the tube at the time of the surgery while waiting for the encapsulation to occur. And then after that, a valve tube developed to reduce the risk of hypotony associated with the non-valve tube. With valve tube, you have a unidirectional flow resistance, and usually it's begin to work immediately after implanting the tube. It has an elastic membrane of the valve, which is closed at IOP of less than 8 to 12 millimeter mercury, and then reopens again. So what usually the indications for tube surgery? Usually used to be the indications for tube surgery in patients with advanced glaucoma, refractory glaucoma with uncontrolled IOP, and they are not candidate for trabeculectomy, like patients with neovascular glaucoma, patient with penetrating keratoplasty, patient with multiple retinal surgeries and has scleral buckle, a patient with uveitic glaucoma and previously failed trabeculectomy, eye syndrome, epithelial downgrowth, patient with contact lens wearer who need glaucoma filtering surgery, and also patients with refractory pediatrics glaucoma after failed trabeculectomy or trabeculotomy. So then come after the ideas, can we use glaucoma as a primary surgery? Or is it just always to be after trabeculectomy or patients with not candidate for trab? There are many reviews claims that data demonstrate that 72% decrease in the number of trabeculectomy procedure performed with concurrent increasing in the tube surgery implantation between 1994 and 2012. Also, this shift in practice have been apparent in an anonymous survey of the American Glaucoma Society membership, show that there's increased numbers of tube surgery in the last decade comparing them previously. And in most of the recent 2016 survey, tube shunts were preferred to trabeculectomy in 7 scenarios. In patients with prior trabeculectomy or failed trabeculectomy, patient with prior extracap cataract surgery or intracapsular cataract surgery, patient with prior cornea transplant or prior scleral buckling or previous pars plana vitrectomy, uveitic patients, and neovascular glaucoma patients. Trabeculectomy was favored over tube surgery only in eyes with prior phaco emulsification and as initial surgery in patients with primary open-angle glaucoma. Another comparison study between the tube and trab, the primary tube versus trabeculectomy study, which is an ongoing randomized clinical trial comparing a safety and efficacy of tube surgery, a Barvolt tube implantation in virgin eye, in comparing to a trabeculectomy with mitomycin C as a primary procedure. So a summary of the 3 years finding of the study, they found that IOP reduction was greater in trabeculectomy group at all points and less adjunctive medication. but the tube group has a higher failure rate at 1 year, but no significant difference observed or seen at 3 years. In both groups, most of the reason of the failure was insufficient IOP reduction and our need for additional surgery. Complication, mainly early postoperative complication, was more in the TRAB group than the tube group, but no significant difference in the visual outcome or formation of cataract. The study showed that there is no clear superiority of the one procedure over another, but trabeculectomy with mitomycin C has more efficacious in lowering IOP, greater pressure lowering, less medication needed after, but there is more risk of early postoperative complications causing vision loss or requiring return to operating room. So another also study, the tube versus TRAB study, which is randomized trial comparing the Barvel tube versus TRAB with mitomycin C in patients with previous cataract surgery or previous glaucoma surgery. So the results showed that tubes had higher success rate during the first 3 years, similar IOP result, similar rate of adjunctive medication use, higher rate of complication in the TRAB group, but similar rate of serious complication in both groups with similar rate of cataract progression. So we can still, I mean, if you aim for lower teen pressures or low target pressure, most of the surgeons still prefer to do trabeculectomy, but sometimes it's subject to the patient case or the patient condition. But usually most of the TRAB and tube surgeries, usually the patient will have a low mid-teens IOP. So which tube you choose? If you want to choose a valved or non-valved tube. Sometimes it depends on the surgeon preference. Sometimes it depends on the availability of the tube. But according to the studies, if you compare Ahmed Barvel, there's two randomized clinical trials compare the Barvel versus Ahmed, the Ahmed Barvel comparison study and Ahmed versus Barvel study, which the mean IOP in this study was lower in the Barvel group compared with the Ahmed group after 5 years of follow-up and fewer glaucoma medications in the Barvel group. The cumulative failure rate at 5 years was higher in the Ahmed group than Barvel. Increased risk of hypotony was in the Barvel group, as we know, because of the non-valved tube. So before we do the tube surgery, we have to look generally at the patient's health condition to decide would the patients go for local anesthesia, general anesthesia, what type of the valve tube we're going to use, valved or non-valved. It depends also if the aim, if you want like immediate lowering IOP, like patient with neovascular glaucoma have very high IOP, we want a low IOP from the beginning. So that would maybe affect our decision which tube we're going to use. Also, we have to look at the conjunctival condition to decide the location of the implant. So scarring, it depends the location of the scarring, so we can decide the location of the implant. Usually the preferable site is the supratemporal, and then after that, maybe the infranasal. So also the anterior chamber condition, because usually shallow anterior chamber, you want prefer to implant an AC tube, or maybe you have to do combined tube phacosurgery. Sometimes patient with shallow AC with vitrectomized eye, we can do a pars plana tube insertion. And also, of course, you have to rule out the presence of vitreous. Corneal status, elderly patients, maybe it's advisable to do an endothelial cell count to see if the patient is suitable to do a tube surgery in the AC, or the patient pseudophakic, just insert the tube in the sulcus. Tube insertion site, you have to be decided before the surgery in the anterior chamber. The most common, you can do a sulcus tube insertion in patient pseudophakic, or pars plana insertion in patient is a phakic patient with had vitrectomy before, or if combined with retina surgery. So if we go to the surgery technique, I will show a video of Barvel tube implantations, and we can. In the beginning, I usually, I don't know if the video is working here. Yeah. So usually, starting the procedure, I usually use an veiw traction suture. I go half thickness of the cornea, and then I usually put that suture, pull the suture downward and put it under the blepharosphere to give you more exposure. Then after that, I do a radial incision in the conjunctiva, and I do subtenon's blunt dissection. I use an untoothed forceps and Westcott scissor. So usually this tip, I usually start with topical anesthesia, and then I prepare a 2 to 3 cc of a mixed 2% lidocaine plus 0.75 marcaine, and I inject it as in the subtenon space with a curved blunt cannula. And usually I aim the needle toward the optic nerve. So usually it's give a good anesthesia control. Some cases I do general anesthesia, it depends on the patient. And then after that, I go with the curved Stevens, and then I go on the pocket, and then I stretch the curved Steven to do like a blunt dissection. So after that, I isolate the muscle, the lateral rectus, and the superior oblique. And after isolation, the lateral rectus, I usually put the one wing of the plate under the lateral rectus. Of course, the different step here in the Ahmed's tube, that before we putting the plate, you have to do priming of the tube to ensure that the valve is working. And after that, I suture the plate. I'll fix the plate to the sclera with an 809 nylon or 80 proline suture. And after that step, I prepare a 7/0 vicryl suture to do a ligature suture to ligate the tube. So here we using the 7/0 vicryl just to ligate the tube. And after that, I usually irrigate a saline just to make sure there is no leak of fluid. So after that, we do paracentesis, and we can control the AC with normal saline. Here, we usually cut the tube. I relax the tube over the cornea, and then I do a bevel up cutting with Westcott scissors. If you plan to implant the tube on the sulcus, it's better to do bevel down instead of bevel up. Then when I inserting the tube, I usually hold the traction suture and usually pull the eye down, and then go with a curved 23 gauge needle. I usually go 0.75 to 1 millimeter posterior to the limbus. And then when I see half of the bevel under the sclera, I pull backward the traction suture at the same level of the iris plane. And then I insert the tube. If you want to implant the tube in the sulcus, I usually go 2 millimeters back to the limbus. In the pars plana, usually 3 millimeters. Then we can use a scleral patch from a donor sclera, or we can use a process pericardium like tutuplast. You can use cornea, and some surgeons, of course, they do a scleral tunnel to cover the tube. Then we suture the plate, the patch with a 7/0 vicryl. After usually I suture the scleral patch, I do in a barbell tube, I do with a 8/0 vicryl needle, I do a venting slits, 2 fenestrations, and then I leave one WEC suture inside, which can help to lower the IOP in the first postoperative period till we have the vicryl's ligature suture opens. Then just we close the conjunctiva with an 8/0 vicryl or 7/0 vicryl, like a wing sutures, go through the sclera and the conj and go backward. and then it's done. Usually the difference also in Ahmed tubes, I usually leave viscoelastic, viscoat or low molecular weight cohesive viscoelastic just to prevent hypotony after the surgery. So regarding the use of antifibrotic agents during or after Ahmed's or CHAP or Barveld implant, I know that Dr. Sharawi, he used to use mitomycin. I don't have that experience. I never used mitomycin with tube surgery, but going to the literature, there's mixed results have been reported with the use of antifibrotic agent as adjunctive tube surgery. Two randomized clinical trials found that adjunctive mitomycin C in Ahmed tubes didn't improve the surgical success in 1 year. Another study in 2017, retrospective series comparing 56 eyes investigated with adjunctive intraoperative and postoperative mitomycin of veiw compared to the placebo patients, and showed that there is adjunctive mitomycin with using antifibrotics following Ahmed tubes decrease the hypertensive phase and improve the surgical outcome, and without impacting the complication rate after 1 year. An ongoing study, the Ahmed with mitomycin C trials, is an ongoing randomized clinical trial comparing the safety and efficacy of intraoperative and postoperative mitomycin C with Ahmed glaucoma implantation. And there's a presentation in Washington by Kaga and colleagues presented the result of 53 eyes in the mitomycin group compared to 52 eyes in the placebo group. The mitomycin group demonstrated a lower IOP in the early first week post-op and 2 months, 3 months, and up to 1 year, but the difference didn't reach statistical significance. The number of required medications remain lower in the mitomycin group compared to the placebo group. So generally, just go through the complications of tube surgery. Of course, hypotony is one of the major complications, endothelial cell loss and corneal decompensation, tube-related problems, and diplopia and strabismus, tube erosion, migrative plate exposure, and hypertensive phase. I just didn't mention about the postoperative course. Usually with tube, postoperatively, I usually start steroids 4 times a day for up to 1 month, and then we taper. Also antibiotic for 1 week. Sometimes may need to use systemic steroid in special cases, mainly in uveitic patients. We can use systemic steroids. Hypotony and its related problems usually is more common with an unvalved tube, especially if you have incomplete ligation of the tube or you have a large venting slits. Sometimes maybe leak around the tube entrance. Of course, hypotony usually managed conservatively with cycloplegics, increasing steroids, viscoelastic if you have lenticulocorneal contacts, and sometimes revision if needed. Hypertensive phase is one of the most unfavorable complications, usually may predict the failure of the tube. Usually it's increasing in IOP around 30 to 50 millimeter mercury, occurring anywhere between the 2nd and the 6th week postoperatively. The condition, usually it's more occurred with a valved tube than non-valved tube. Usually when the patient have a high IOP, usually early start of aqueous suppression. I usually start with aqueous suppression. Once I get the pressure over 10, 11, I start aqueous suppression. Sometimes massaging may help, digital massage, bleb needling with or without veiw doesn't show a big difference, and possible surgical excision. If the patients fall, if every measure fails, a second drainage implant may be needed or cyclodestructive procedure. So a key point from this talk, that's tube surgery being selected with increasing frequency as alternative to trabeculectomy in many clinical situations. The primary tube versus trab study showed that trabeculectomy with mitomycin C had a higher success rate, but more postoperative complication than tube shunt. The Ahmed Barveld comparison study and Ahmed versus Barveld study showed that Barveld implant has reduced IOP more than Ahmed valve and less safety profile compared with Ahmed valve. The use of adjunctive mitomycin C with tube shunt may improve the surgical success and decrease the incidence of hypertensive phase. Placement of second tube shunt surgery is as effective as primary tube shunt implantation and comparable to cyclophotocoagulation in patients with experienced primary shunt failure. Thank you.
Thank you very much, Dr. Nawaf. I want to ask you about neovascular glaucoma. What is your experience with valve surgery in neovascular glaucoma? And you prefer to do it as a primary procedure, or you want to do TRAB first?
Yeah. Actually, with neovascular glaucoma, I usually go with tube first.
As a primary procedure.
As a primary procedure, I usually go with tube first. Sometimes also, if I send my patient to my retina colleague, just do 360 PRP, and you give an injection of Lucentis or Avastin. Any intravitreal injection, or sometimes if the patient like came as emergency, like with pressure 60 in pain, I usually do a tube and give intravitreal injection at the same time.
Yeah, Dr. Rashmi, I think have different way to use with neovascular glaucoma. I think she preferred to do TRAB first. Is it? Dr. Rashmi, can you hear me? Just put and do an unmute. Yes. Dr. Rashmi?
I didn't get you.
Yeah, I said that you have a different experience in neovascular glaucoma. You like to do TRAB first. You don't like to do, valve surgery as a primary procedure in neovascular glaucoma. What's your,
So we usually do trabeculectomy with mitomycin C as a primary procedure in NVG, especially in those eyes where the PRP has been done and the new vessels have regressed, or we give the anti-VEGF and then wait for 3-4 days and then do the TRAB. And we have just analyzed the outcomes of TRAB in NVG. It is almost around 80%. So we primarily first surgery in an NVG, we do a TRAB only. And then if it fails, then the second surgery would be a tube.
Prof. Tariq, what's your experience with neovascular glaucoma in tube surgery? You prefer to...
my tubes are the primary procedure for me in neovascular glaucoma. So, it really depends on many things. Most of my neovascular glaucoma cases are very elderly patients. And the economic aspect of using the tubes is not a huge issue in where I practice. So I go ahead with a tube, hoping for a post-operative period that is less demanding on the patient and the surgeon compared to trabeculectomy.
And Dr. Sharawi, I know you're using mitomycin with tubes. So you usually use it as a sponge or injection?
No, I actually use it as a sponge, but I use corneal shields. I cut corneal shields in half. Okay. I soak them with mitomycin. I put them in the pocket for 2 minutes, and then I agree with you that it is very, let's say, controversial, and there's no true evidence based to using mitomycin versus not using the mitomycin. Maybe it's a psychological comfort zone for me to use mitomycin with tubes rather than basing it on true science.
Maybe I should try it.
Thank you, Dr. Nawaf. Just coming to Prof. Tariq for minimal invasive glaucoma surgery. You can start, Prof. Tariq.
Okay.
Yes.
So let's see. Trying to see if that would work. Hold on, please. Yeah. Okay, does that work? Can you see my slides?
Yes, we can see.
Very good. Okay. So a bit on minimally invasive glaucoma surgery, and I've been asked by my colleague, Dr. Muhammad. Thank you very much for the invitation. It's a pleasure to be with you here today. I have to say that I've enjoyed it tremendously, and I've learned from the three of you a lot of stuff that I'm going to use in my practice when I get back to my practice. For the last 2 months now, I've been working in the Geneva ambulance service, and I have not touched or seen an ophthalmic patient for up to 2 months, and I'm stuck there for perhaps another month. So I'm looking forward to getting back to my practice. Anyway, the four specific types of glaucoma surgery that we're all used to are trabeculectomies, tubes, non-penetrating glaucoma surgery, and cyclodestruction. All of a sudden, we are now confronted with multiple different devices, as you can see here, and they're all vying for our interest and for our practices. And I decided to just look at it, and for me, it's a mixed bowl of salad, and I would like to start by, classifying what is minimally invasive glaucoma surgery. Now, classification has to be based on something, and people can classify it on a terminology. Minimally invasive glaucoma surgery, which is to me, is basically a marketing term, doesn't have any science into it. Or we can say it spares or preserves conjunctiva. We can classify it as related to how it handles the angle. Are we using implants or not? Or finally, my preferred way of classification of all glaucoma surgery is basing our classification on strategy. So basically, as you can imagine, we have four types of strategies to reduce intraocular pressure surgically. One is going into the subconjunctival space. Second is addressing the conventional pathway through the trabeculum. The third is going into the suprachoroidal space and opening this strategic area, or finally to close production or shut down production in one form or another of cyclodestruction. Now, all of those strategies can be addressed from outside of the eye or from inside of the eye, so ab externo or ab interno. And based on that, you can see now my flow chart or my classification of glaucoma surgery as it is now. Now it can again, subconjunctival filtration, enhancing SCHLEMM'S canal, suprachoroidal filtration or cyclodestruction, and then subdivide them into ab interno or ab externo. And this is where we are very, these three places are where we are most experienced in: the trab, tubes, and non-penetrating procedure area. But within subconjunctival filtration, we have now ab interno Zen implants and ab externo arrow or micro. It has gone through different names. So I still use the arrow term, but now the commercial term for this device is pressure flow. And we're going to go into that in a minute. So briefly, let's look at landscape of what we have, what is the good and bad, how do we look into success, and all about the peer pressure related to that. And also we need to look at, when we speak about success for me is not just a reduction in intraocular pressure, but it also is preservation of vision. It is also means preservation of the comfort of the eye. This is the CyPass, a very small device, as you can see here, that I've started working with many years. I think back in 2005 or 6 was the first time I put a CyPass in. And this is actually my first ever operation of CyPass. Again, putting into the suprachoroidal space. Unfortunately, a year and a half ago, Alcon actually voluntarily withdrew CyPass. Why? Because they found that if you compare CyPass with phaco to phaco alone, there is a significant reduction in endothelial cell density after 3-4 years of putting the CyPass. So whatever we're doing, we have to look into it, not just at what is happening at this point of time, not what is happening in a year or two, but we have to look longitudinally and into the medium and long term. And many of what we're doing is based on the fact that we find the technique, we like how it is, the surgery is engaging, the surgery is attractive. So we jump into it without really spending enough time to learn much about it. So endothelial cells, I've published with my group a couple of studies showing that tubes, for example, something bigger than most of the devices in minimally invasive bracket, is associated with loss of endothelial cells as you keep it inside the eye prospectively and for a prolonged period. So please don't forget that when you're putting a tube, there is a price that is going to be paid, and is going to be paid daily. Now back to our flow, and from all this, let's take a look at why subconjunctival filtration remains at this point of time the most attractive aspect. Well, we know subconjunctival filtration, we can manipulate it postoperatively, and that's a huge, huge advantage, because if you put something into SCHLEMM'S canal or into the trabeculum, you basically do the surgery and then you pray for the operation to work, and because there's very little manipulation that you can do afterwards. Subconjunctival filtration is something that you can manipulate postoperatively. If healing starts to kick in, you can needle, you can revisit, you can apply again mitomycin. And the good thing about the new devices, whether ab external or ab internal, basically the Zen and the pressure flow, is that they're associated with what I call a hybrid blebs. So you look at, this is a case of a pressure flow, and it is functioning, the pressure is around 12, but the filtration bleb is shallow, nothing is prominent, and it is further away from the limbus. We're used to let me show you that again. We are used to filtration blebs limbal around the limbus, but what we have here is something that is 6 millimeters away. It is not as far as a tube, but it is midway between a tube and a deep sclerectomy or trabeculectomy. That's why I like to call it a hybrid bleb. Now, the length of the tube and the lumen of the tube is something that is extremely different from one device to the other, with the understanding that that would definitely have repercussions on success rates. If you can look at the Ahmed valve tube, which we obviously shorten, is 2.5 centimeters, while the Zen implant is 6 millimeters and the pressure flow is 8.5 millimeters. Taking all that in consideration, we have to figure out that the length and the lumen size is something that determines, according to the Poiseuille law, the degree of reduction, at least in the early post-operative period, because the long-term reduction in pressure and stability of pressure depends on the scarring that happens around the filtering site, as you all know. Now, share with you some videos about the pressure flow, which is at this point of time a device that I find quite promising. I have no commercial interest in the device. And you can see you mark at 3 millimeters. From there, you put a spatulated knife that doesn't go into the antechamber. It just creates a pocket. And after creating this pocket, you perforate into the antechamber using a needle, as you can see here. So this goes all the way into the antechamber. And as you can see here, we go really deep and we perforate into the antechamber. Now, from there on, we thread the device, as you can see, slowly into through the pocket. And the 2 winglets that you have here are things that are designed to prevent migration. So the device is tucked into the sclera, remains there, and does not migrate, which is really an interesting feature of the device. If by the after implantation, you can observe filtration happening, and you can gauge how much of the aqueous is coming out, as you can see here. The other device that competes with the pressure flow is the Zen implant. You can see that the Zen implant is loaded into the lumen of a needle, same way as a trocar and a cannula. The device is that small compared to the Ahmed valve. And it comes with a very interestingly designed injector with a stoppage cork that you take out. From there on, you go from inside, you penetrate through a paracentesis, and from ab internal, you stabilize the eye with a second hook, and you slowly come out into the subconjunctival space. And maybe this video should show you that better. Here is marking, and I'm using an anesthesia of topical cocaine 5%. This is what I use for almost all of my surgeries, whether phaco's or glaucomas. And you can see here from inside the eye, we're penetrating to get outside into the subconjunctival space. You see the bevel as it penetrates the sclera here into the subconjunctival space. Once you are there, you basically push the tube into the subconjunctival space and make sure that it is well tucked and not corrugated. And at the end of the operation, you can maybe see a bit the Zen implant here, this yellow thing. And by the end of the operation, you see a filtration bleb forming on the table, which is a good sign. And obviously the conjunctiva is not opened at any point of time. So you irrigate and get out all the viscoelastic, and you can see here a big beb forming at the end of the operation. Now, not all devices or not all operations have a good, results at the end. This is a case of an extruded Zen implant. I show you that again. Patient comes in a couple of months after the operation, and the tube has actually come out and eroded, and in front of the slit lamp, I just pick it out. And this patient has developed a good amount of hypotony after removing the tube, which was perplexing for me, but doing a gonioscopy or gonioscopic evaluation, you find a ciliocoroidal cleft, a huge, relatively huge one that has formed at the place where the implant was. So you can appreciate the whitish appearance here of the ciliocoroidal cleft. And this patient, we had to go and surgically repair the ciliocoroidal cleft. So MIGs are there, but they come with new specific set of complications. With all that we have here, we also should not forget all those devices that enhance SCHLEMM'S canal by inserting a tube into it, like the hydrus, like the eye stent. Those are definitely very interesting devices. And we still need to know a little bit about how is the luminal flow of aqueous once you bypass the trabecular meshwork. We need to know a bit more about wound healing in SCHLEMM'S canal. We don't have enough information. Here is the Glaucus eye stent, a device that is relatively easy to use and has met with a lot of success, especially in North American markets. And here is the hydrus implant, which is a titanium scaffold that you inject into SCHLEMM'S canal, which basically is very similar to catheterizing a coronary for cardiothoracic surgeons. And a study that was published after 2 years to show that if you do phaco alone versus phaco with hydrus, you have a certain significant reduction in pressure. By significant here, I mean a reduction of 19 to 17. So that is also something that should be, you should look at and see if that is pertinent for your patients or not. I think MIGS will take its big leap when we can start understanding the flow of aqueous and the outflow of aqueous. And this is, as you can see here, a scanning laser ophthalmoscope or scanning laser microscope to be able to look at that. Alex Huang and is really a pioneer in that, trying to give us a better understanding. And that one day we will be able to actually image the aqueous intraoperatively, and based on that we can then place our devices in the right place to maximize the amount of aqueous or of pressure reduction. But when you are making a decision about what operation to do, you have to remember that your decisions should not be based on your own biases. Biases like the last operation that I've done was good or bad, and basing my decision for the next operation on only the last operation, not on data that I have or international data that was published. Making a decision based on peer pressure. I work in this center and I've been doing that, but this other center has started doing something else and it looks sexy, so why don't I do it as well? This is actually, as you can see here, the cognitive bias codex used by psychologists and psychiatrists, and you can see how many biases that we have. Beware of peer pressure. I don't want to take too much time of yours, but I want to remind you and let you meet one of my patients who is a single-eyed patient, and the decision to which operation to do is quite sensitive, and you have to align the surgical risks that you're taking with the stage and rate of progression of this patient. A patient that is not progressing and stable, there's no reason really to operate. A patient that is progressing slowly might need an operation that reduces the pressure a bit, but not too much. And henceforth. So you have to really consider the patient, consider your skill level, consider the choices that are available for you from a technical and economical standpoint before you make your own decision. These are my phone numbers. If you are interested to contact me, I'm also available on Twitter and on Facebook. With that, I thank you very much. I wish those of you who are doing Ramadan Kareem, taqabbal Allahu minkum. And with that, I end my talk, and I hope that wasn't too boring. Thank you very much.
Thank you very much, Prof. Tariq. It was very nice presentation. Minimal invasive glaucoma surgery is still considered to mild glaucoma, or just or you are doing for moderate to severe also?
When you say considered, it applies a conventional wisdom or a conventional opinion, which I do not think it exists, meaning that not everybody agrees on what to do with minimally invasive glaucoma surgery. I have been using minimally invasive glaucoma surgery like pressure flow or Zen, mainly in combined cases. And I have started using pressure flow in early to moderate cases. But I have not used any of those devices as in advanced cases, with some exception at the time when I started CyPass. So I had cases that had 2 tubes after 2 trabeculectomies and the deep sclerectomy, and there was no conjunctiva. In those cases, I opted for suprachoroidal filtration with a CyPass or the iStent Supra. And I met with mixed bag of success. Some cases went well, some cases didn't go well at all. But I still think that we don't have enough evidence to use those new techniques for advanced cases.
Okay, thank you, Dr. Tariq.
Dr. Sharaway, I have a question. Have you seen any tube extrusion in cases of pressure flow?
I'm sorry, say that again?
A tube extrusion or explantation in cases of pressure flow?
I never had that with pressure flow. Pressure flow is very malleable and softish. While I had it with Zen at least in 2 times, probably because the Zen is a bit more stiffer, but erosions are rare, but they do happen. And between you and I, and since we're talking you and I alone and nobody's listening, I can tell you that I feel that most of those tubes are working because there's a flow around them, not because of the flow through them. And I have some UBM evidence to that. I think that they're doing some sort of a very well-controlled suprachoroidal detachments, and there's a extra luminal flow rather than what is coming through them. But again, it's something, it's a work in progress.
Okay. Is there any foreign body sensation that the patient complains of?
Not at all.
Okay.
Thank you, Dr. Tariq. There is one question about trabeculectomy. One just asked, do you not do paracentesis? No, actually, I like to do paracentesis in all adult cases, but in pediatric glaucoma, I don't like to do paracentesis. I think Dr. Rashmi has a different experience in LV. They don't like to do paracentesis, and they don't like to form the EC after trabeculectomy. Can you speak a little about this?
It is like we do surgery the way we have learned from our teachers. So none of the surgeons in LDT, they form the AC, and they basically the idea is once we enter the AC, we feel that there is a higher risk of cataract formation because of the fluctuation in the antechamber depth. So even though the AC shallows when we do the trabeculectomy ostium, and by the end of the surgery, there is the antechamber formation because of the formation of the aqueous. So we usually don't do paracentesis. If at all the AC totally flattens, I have personally filled the AC with the fluid through the flap, the sides of the flap, through the ostium itself, from the anterior chamber, but not to titrate the flow of the aqueous.
Yeah, thank you very much, Dr. Rashmi. Dr. Nawaf, you are used to do paracentesis in TRAB, huh?
Yeah, I do paracentesis.
And Dr. Tariq also?
I do paracentesis in trabeculectomies. I don't do them in deep sclerectomies.
Yeah. Okay, then thank you very much for all of you. Thank you very much, Dr. Tariq, for joining us. Thank you, Dr. Nawaf and Dr.
Thank you very much.
Rashmi.
It's a pleasure. Thank you.
Yeah.
Thank you everyone. It's a pleasure listening to you all, and thank you.
I offer my thanks as well, and I especially thank my co-speakers, because I come out of this having learned a lot. Thank you very much.
Thank you very much. Thank you.
Thank you. Thank you.
Dr. Tariq.
Thank you.
Bye.
Bye.
Bye.